This episode of HIPcast is sponsored by FairCode. Are you looking to maximize your hospital's revenue and streamline patient documentation? Introducing FairCode, your trusted partner in DRG reimbursement optimization. FairCode's 100% board-certified physicians collaborate seamlessly with your coding, CDI, and medical teams to conduct lightning-fast chart reviews, pre-bill and post-discharge to ensure accurate reimbursement. Only 10 to 15% of the chart's FairCode reviews requires changes, yet their recommendations result in a significant boost to a health system's cash flow. Are you worried about risk? Try FairCode's 13-week trial. If they can't pay for their services, they'll keep reviewing charts until they do. And by the way, historically, FairCode's 13-week trial leads to ongoing partnership with a remarkable 3-to-1 hard dollar ROI. Don't miss out on the opportunity to enhance your reimbursements. For more information about FairCode and how you can experience the maximum in healthcare revenue optimization, contact Steve Hansen at 615-600-2166.
Well, today we are really what I'll say back for round 2 with Daniel Utech. Technical challenges, or maybe we just say really great privacy and security protocols prevented us from being able to share with you the first recording we did of this amazing conversation. So we're going to have a do-over here. So today we have the privilege of bringing you Daniel Utech. He is a passionate advocate for health information and has emerged as a leader in the field. Over the years, he has taken up the pivotal leadership roles at various organizations spanning Albuquerque to Dallas, specializing in HIM and IT. He is committed to giving back and has consistently volunteered at both state and national levels, working closely with New Mexico HIMA, Texas HIMA, and the AHIMA Advocacy Policy Council, among others. Beyond his professional pursuits, Daniel is a shade tree mechanic and a carpenter, currently building a cedar pergola. His dedication has recently been recognized with the election to the Board of AHIMA Directors. Additionally, he shares his knowledge as an adjunct professor at HIM at the DeVry University. Sorry, I stumbled through that some. Daniel, tell me about the pergola and the progress there.
Yeah, it's going well. I am building a pergola in our house. It's fairly large, but it's fun. It's one of my staff was like, "Oh, that's like your therapy," and I was like, "Yeah, I think it is." You get out there and you can enjoy doing something, and then when you get done doing that, you get to kind of see the results of it and enjoy that. I think that's a lot of what brings me to the HIM field too, is that we get our hands in a lot of different activities within our organizations, within our community, and it allows for us to be able to add some value for the organization, for patients, or like I said, our community, our friends and family, and then at the same time, you get to see the results of it, and it's kind of fun.
That's
It is
awesome.
a lot of fun. And, today's episode is going to be about a health information professional in the IT world, right? And Daniel and I both have sort of lived that life a little bit. And then we were co-chairs of the AHIMA Advocacy and Policy Council. That's where we got to know each other and had a lot of fun doing that as well. So today we're going to talk through a little bit of both, a little bit of the IT world, a little bit of data governance kind of stuff, and then a little bit of the National Association and volunteer items. But you touched on getting into the health information profession. Tell us about your HI journey and how you ended up where you are today.
Yeah, I mean, it's been an interesting kind of progress. I think, when I started, like a lot of, I think, HI professionals, that wasn't like we were in high school, like, oh, you know what I'm going to do when I grow up? I'm going to be in health information. And so for me, it was, I wanted to be in healthcare. I thought, maybe something at the bedside would be, up my alley until I had the opportunity. The program that I was in required us. I was starting in a nursing program, and required you to get your CNA as a part of that kind of pre-program. I did that and realized, bedside wasn't for me, but I still wanted to find ways to be able to serve that community because it's kind of an intrinsic motivator for me to be able to give back to the community in a valuable way. And so what I found was I had some credits in health information related stuff. I did all the nursing kind of prereqs. And then at the same time, I still had an interest in IT stuff. I'd done some programming classes and stuff. I found that interesting. And HIM, health information, was just kind of it made sense. I mean, ultimately it was a sit down with my advisor, look at the classes that I'd already taken, my interests, and what would help me kind of finish my pursuits in my bachelor's, and health information made sense. And so then a part of that program at the College of St. Scholastica, they had us do kind of 3 different practicums. One was kind of focused on operations in HI, one was focused on management, and one was like you could do something that was not necessarily a standard. And that one for me was really interesting. I got to go work with the AHIMA's public policy team and governance team in Washington, D.C. And so that was really kind of where I found a lot of interests and found a way that I could continue to give back to the community. So for me, it was really fun and lively. And you get to see ways that you're able to make a really a large sphere of influence on the industry, because you're helping create those regulations. And then, of course, once you get them, how do you interpret them and implement them?
Yeah. So how'd you end up making the shift over into IT?
A great question. So I think for me, my first job was at University of Mexico Hospital in Albuquerque, and I worked in the health information department. That's where I'd worked majority of the years of my career, at least up to this point. And for that, it was really focused on, how can I create those relationships with IT, recognizing at that time that our whole infrastructure relied on that group and the work that they produced. And so for me, it was, hey, how can I, create those relationships? So that was a big part of it. Was I built bridges between the HI department and the IT department to get things done and to help them reduce any issues, right? Because every time there's a new upgrade or, some kind of update, oftentimes it would break something for our staff. And with coders, especially being in transcriptionists at the time, being on a production basis, they had to meet it. Transcriptionists, they were paid by the line. So when their stuff wasn't working, they couldn't make money, let alone get the, records updated for our patients to be able to be treated the way that we would want it. So that was kind of really my first entrance into that. And with my role there, I was able to do some systems analysis work within the HI department as well. So that my senior director there kind of recognized my acumen for it. And then, of course, the relationships I developed. So there was an opportunity for our HIM department to have its own systems analyst. So I was one of those 2 systems analysts and worked in that capacity there. And then when I left there, I got back into HIM operations at Texas Health Resources here in Dallas, Fort Worth. And even in that capacity, I was working a lot with like data and analytics and trying to create some really good data visuals that would help us make decisions with our DNFB and our work in progress reports for all the documents that providers still had outstanding that we had to get done to be able to get, dollars out the door. And with, I think it was like 14 or 15 organizations and that many CFOs, you had to have some good data to support why you needed to suspend Dr. So-and-so, who was also their primary admitter.
Yeah.
So you
fun
had to
conversations.
Right. Exactly. But when you have the data to support it, and that's always been my focus, was how do I kind of get that component of it? And so I really focused on how do I create, good data for decision making, which is really what the EHR is. It's a tool to help us make better decisions with more information. And so I think, I was able to capture that from a HIM perspective for our needs in that respect. And then I took on a role at Parkland Health. And at Parkland, there was opportunities that had opened up, for me to get my MBA. So I did that through Parkland and, again, was able to build bridges between our department and IT. And, it wasn't like the first time I interviewed that I got the job in IT. But after some successive interviews and, again, establishing some relationships and rapport with folks, it gave me an opportunity to take on the role that I have today, where I lead a IT business partner team, kind of business analysts, writing business cases for the entire enterprise, as well as an application team. So it's been a bit of a journey, but I think I'm in the right space for me and my skills. And then I've hired a lot of health information professionals. So there's been several people from the HIM department at Parkland who have taken on roles within my team. And so we're really excited to be able to continue to show the wealth of expertise and knowledge that our profession brings.
That's awesome. A couple of things about that. First of all, you're still advocating for our profession from the IT side by bringing over keeping the bridges between IT and HIM, and then hiring those folks into IT also. But a question: when was it you said it kind of started your IT journey? Almost kind of started from a practical standpoint when you were at New Mexico. What years were those?
I want to say it was like 2010 or 11 is when I was officially in the HIM department, but I was a systems analyst. So I think that was around 2010 or 2011.
Okay, so right around the time of meaningful use.
Yeah, it was. Yes,
Okay.
we had a lot of meaningful use stuff. I ended up being sort of a project manager at one point for our meaningful use project and working with our CMO and trying to get the vendors that we needed to have in that space to make sure it was meaningful and useful. I think most of us that have been in the industry long enough heard all the other things it was called, but we were trying to make it that.
Yeah, Seth, that's about the same time for you also, right?
It is, yeah, and our stories are fascinatingly close because
They are.
I talk about this quite a bit in our mentor program in the state of Tennessee. We have with students. A lot of times, I'll have either students or young professionals that will ask me, "How do I make the jump from the health information profession over to IT?" And just like Daniel, Daniel says he went and built bridges, and I just more irritated everybody to death until they would talk to me, and got to know the CIO and CTO very well. And I wanted to learn about a data center, so I asked the CTO. I said, "Would you tell me about the data center? I'll come over here. I'll spend an hour in the morning, buy you coffee, and you can walk me through and explain everything that's going on in there." And that's kind of how I learned IT. And then on the other side of that was when the Affordable Care Act was going on. And I had done a couple projects, just like Daniel mentioned there. And the CIO was like, "Hey, as a health information professional, you seem to know all of the landmines, all the gossip, all the fun stories, the skeletons of the hospital. Can you help us run our EMR project?" And I thought, yeah, I'll go do that. So that's kind of how I flipped over to IT. It's very similar to Daniel's story.
Yeah.
I'd be curious, Daniel, on the IT side, if your experience is similar to mine of how does a HI professional fare in the IT world. Sometimes that's a challenge, but sometimes it's also we're the shining stars because we do know where all the skeletons are and we know all the gossip.
Yeah, I find that the team members that I have that have health information experience, whether that would be, they had an education in it more formally, or they worked in the department, or a little bit of both, that they bring I would say, a more full palette of colors to those projects and initiatives that they're involved in, primarily because they can think about it from end to end. They can think about that longitudinal record from end to end. How do we get the connectivity that we have? How do we make sure that we're documenting things in the right place and capturing the information that's really needed, not only for the patient care to continue in the multiple places that it can nowadays, whether it be at home or at other facilities, but also just making sure we're meeting some of those regulatory requirements that they're familiar with. I think, you talked about the Affordable Care Act, but really the 21st Century Cures Act has, I think, been the biggest challenge for a lot of our profession and our industry is how do we meet those things, but do it in a way that's not going to be as paternalistic as maybe have historically been, where we haven't shared information to protect people, when sometimes that kind of does the opposite. So I think for me, there's certainly a lot of added value there. And I think a lot of it too is our staff are focused on not saying no or but it's yes and.
That's good.
That's a great idea, and we should consider this other component of it, right? And I think that's a big part about being at the table. I think that's something I've heard all through my career in health information, but really IT is in the same space. If you go listen to any IT related speakers, they're talking about how do we get at the table? People are like, well, you're automatically there because you bring the computer. I'm like, no, we're not. They come to us with a solution. They go make it happen. And you're like, actually, and this is a big thing. A big thing for me is empowering my people to say, hey, y'all are the subject matter experts. You're not there just to do something. You're there to add value to the process. And a lot of times we have to follow up with questions like, well, what problem are we fixing? I know you gave me a solution. And I think that's a really difficult part because a lot of our leaders are there because they are very solution focused, and they've been able to achieve a lot of great results with that attitude and mindset, which is wonderful. However, I think we still have to be able to have those conversations of, well, what problem are we solving for? So we make sure we actually achieve that result. And I think with our HI professionals, because they get a broader view of health information and the healthcare system, we bring a lot more to the table. And I think I can compare that to some of my colleagues in the more technical infrastructure side, working on servers or working in the information security space. A lot of those folks are subject matter experts, but they haven't had much of any experience in healthcare.
Mm-hmm.
So they don't necessarily recognize some of the things that they do that protect us, which is great. We need that, especially today. And you probably see a headline every other day for some kind of information security breach. But we have to be able to still provide the core part of our business, which is taking care of people. And so I think our health information professionals really bring that perspective. Like I said, they really understand the gambit of the information we're collecting, why we're collecting it, how to collect it, what the impacts are. So I think for me that I'm very much biased in my response, but I think that they bring a lot of added value where I don't necessarily always see that right off the bat with somebody who doesn't have that experience.
Yeah, and I'll say I appreciate that for both of you because you do have health information and also IT experience. As a person who I do have both, but my IT experience is a lot more limited than both of you. And so in some organizations, as a health information professional, thinking about, the data flow as the content and the context and not necessarily the network and the system diagram, right? I'm thinking about the data flows in the data diagram, and they're thinking about system flows and, the entry points and where is it vulnerable and that, where is it going out to, which they should, that's appropriate. But I've met with a lot more resistance than what you both just spoke of from an IT perspective. I meet with a lot of resistance sometimes. And I think sometimes it depends on the type of organization. And sometimes it depends on the size of the organization. And then sometimes it is just the leadership and the culture of the team you're working on, who's leading a project. So it is how collaborative is a project versus how authoritative is the leader. This is how it's going to be without respect to, or maybe that leader is an IT focused person, or like you said, here's the solution. Maybe they're the solution focused person. They don't understand the driver of IT. The IT has to be the driver, right? They are driving our car, even if we're the components. And so I have met with more resistance. And so I wonder if and probably, I will admit, probably some of that is my personality. I'm like a bull in a china shop. So I'm not always the most graceful. But I've seen that
microphone real quick here.
I've heard it from other health information professionals too. But maybe quickly, Daniel, and Seth, you chime in on this also because you both have experience here. Maybe just a real quick piece of advice to a health information professional who needs to collaborate with IT to successfully get a project completed. What is something that they can do to soften that relationship or to gain the respect of that IT side of it so that they can understand, like, is there a magic word? Is there a magic phrase, or what? Help us here. Help the HIM community be better at this.
Yeah, I think for me, there's a couple of things that I would suggest. I think one is we still need to acknowledge that, we still live in a space in this country where there's, people that have bias and they don't always acknowledge their bias when they're coming into situations. So if you're working with somebody, being a white male, it makes it a little bit easier sometimes. And I acknowledge that. But I think that isn't always the case for some of our peers, right? When they're dealing with folks, not everybody's aware of their biases. We all have them. We just got to have some awareness so we can address it. So I think first I like to address that because I think that's something that, is something important to talk about. If you're getting in that space, can you always confront the leader like a bull in a china shop? Maybe not. That might not be the right way to go about it, but there's definitely ways to do it within the organization and working with different people. Sometimes it's a matter of just talk to their admin. Hey, I got this weird vibe from so-and-so today. Is that normal? What should I expect? I really want to be able to foster this relationship and build these bridges. So those are some things to maybe consider and think about. That's one of the ways that I've worked through it. When I get a weird vibe, and there was this a gentleman that I always worked with at one point. He was in a committee with me, and I was the representative for HIM at the time for that committee. And every time I'd get there, I think he'd forget, or maybe intentionally, he'd tell me a story about when he was in the military. And one time he was going to a committee meeting with a general, and he sat at the table, and the general's like, "No, son, you sit over there on the wall." And he'd always tell me this story, and I look young, and I looked even younger then. And so I think he was trying to tell me something. I'm like, "Well, this is my seat, so thanks." But at the end of the day, I didn't feel like I'd have any ramifications from me in that situation. So, I felt safe to do that. But certainly working with folks, admins, I find oftentimes is really helpful, because sometimes they'll be like, "Oh, I can't meet with you." But so I'll talk to their admin, and their admin runs over to their office, brings them, they print out the email, walk over there, get an answer, come back and tell me what's what. I think the other thing too, like I mentioned earlier, I find in HIM, it's easy for us to say no, somebody can't do something. And for good reason. There's regulations, there's safety concerns, all these great reasons to say no. Where I think we come into some trouble with that is if we are always the people that say no, people tend to leave you out because, you're no fun. You always just say no. And so if you come into the situation where you're like, well, maybe we could think about it this way, or, yes, and, or you can still say no, but how about some other opportunities? Maybe we could try this, or this. So that's some of the things that I've seen be somewhat successful. There is no magic bullet, but that's some of what I got.
Yeah, that's good. That last part, especially. So listen up, HIM professionals out there. Like, don't always say no. Really think critically. Like, is there a way to solution this where you can still be compliant with whatever it is that at first gives you that, hey, I don't want to wear it. I don't want to end up wearing orange. What about you, Seth? Anything to add there?
The only thing I'll add is I always like to look at the perspective of who I'm going to talk to. And a lot of times if you're going to approach IT, whether it's the field service tech all the way up to the CIO, their daily lives I always put it in the concept of like a government worker, right? The DMV folks are not the friendliest people in the world, but it's because their job never ends. They never have the light at the end of the tunnel. It's always just more, and it's always do more, and it's always compounding, and then it turns over because my license just expired. So now you're going to see me again.
Start over.
And so they, a lot of people give government workers a hard time, but if you look at it from their perspective, it's just the work never ends. And IT sometimes has that mindset of anytime somebody comes to me with a problem, or as Daniel mentioned, they most of the time come with the solution before they identify the problem. The immediate response is, I've already got 200 projects going on. I'm already managing 200 applications. I'm already managing 15,000 endpoints. I can't take on one more thing. So you have to soften that approach, knowing that in IT, it's just one more project, it's just more work, and it's never ending.
Yeah.
And that's a really good point. I think one of the things that my organization we've focused on is kind of the idea of capacity planning, or some kind of governance that's organization wide. And I think a lot of organizations kind of can struggle with that, where you have everybody that's got amazing ideas that will do great things. And they're all good ideas, but how do you then say, well, which ones can we do this year? And I think a lot of organizations do a good job with saying, this is how much money we have to spend this year. So they do budgeting for money and financial resources, but not for human resources.
Yeah.
They do when they're like, oh, we need a new FTE. I'm like, yeah, but that's a financial decision. You're not saying how many people in this department can do how much work. There's only 2,080 hours for a single FTE. You got 10 of those. Well, that's 20,000 hours. That's it. Beyond that, you're looking at overtime or contracted services, which usually require additional internal FTEs anyway. So I think organizations struggle with that. So I think, again, from an HIM perspective, if we're trying to bring ideas for new solutions, I think it's working with maybe whoever those IT application owners are. So maybe trying to find out who that might be, who's responsible or accountable for that sector or that set suite of applications, and then working with them to say, again, this is the problem we're identifying. Are there solutions we already have that maybe achieve this? I know vendor so-and-so sold me on this because Lexmark is great and it's got the best products in the industry and I really need to buy that. But maybe we already have another product that meets some of those needs. And I think having some of that conversation and just talking through it together oftentimes helps to create those partnerships. And then I think ultimately, like Seth said, just remember HIM, we were both in the basement together.
Yeah.
IT's right next door. You walk down the hall, there's
That's
the
right.
servers, there's their offices. They don't get lights, they don't get windows. They get
true.
forgotten about, left off the table, left out of the budget till it's too late. So I think we have a lot in common, and I think we can lean on some of those commonalities to again help us to really be able to figure out how we can continue to work together. I think we do a pretty good job in most places I've been. It's just continuing to bridge that gap, and especially the 21st Century Cures Act, I think, was a wonderful way to do that. If you that was the stage to be involved in, and it's going to keep changing. It's going to keep adding more as we go. So I think if you haven't had that opportunity, use stuff like that and go, hey, I have some folks that have expertise.
Yeah.
We got the in because we got the government policy team with the HIMA sending us all these great updates coming from Lauren Ripplinger and gang. Let me help you with that. And I've brought some of that stuff up to our legal affairs team. And they're like, oh, that's a good question. We'll get back to you with how we're going to do X, Y, Z. So I think just planting little seeds like that throughout your time in partnership with folks helps.
Yeah, that's a good nod to Lauren Ripplinger. Everybody doesn't have one of those. We're really fortunate to have a Lauren Ripplinger. Oh, she is so the best. So we're really fortunate. Daniel, I'm going to ask you a couple more questions related to data governance in just one second, but I do want to go back to, you mentioned bias, and you talked about you're a white male and you're going to call out your bias and recognize that. And I think, there are three major biases, or recognized, widely known biases, right? There's age, race, and gender. Okay.
Mm-hmm.
But let's also talk about, and those are important, but let's also talk about our own biases against IT, or IT's biases against health information professionals, or the clinical staff against health information, or health information against clinical staff. So I think that was such an important point, and I didn't want to miss that, not only about our person, but also across lines in our profession. I think it's really important to recognize your own professional biases and recognize that other folks may have professional biases against your profession because of their past experience with somebody bringing them a solution, saying, here, plug this in and make it work. That's hard to do. So I appreciate that you brought that up, and I wanted to cover that a little more. So I'm going to move on to data governance. And I'm going to ask you kind of a couple of questions in one, because I don't want to run us too long over time here. So with health information professionals and our unique skills related to data governance, first of all, how do we exercise, or how do you and your team, especially of those health information professionals that you hired, how do you exercise those within IT? And then the second question that you can kind of follow up on are, do you have any tech currently, or do you see any on the horizon related to helping you manage data governance in IT, at least as it relates to health information?
Yeah, I think to your first question, I feel like for me, a lot of that is just based on making sure people have familiarity. And so we carve out time. Actually, we use Microsoft Outlook. Microsoft Outlook has a good tool called Viva Insights. And so you can set up with Microsoft Viva to automatically schedule time for you for learning, for focus time. You can have a virtual commute that reminds you to leave, and you have kind of a little break between work and you're leaving the back door, getting into the house, right? So I think tools like that help. But one of the things that those Viva Insights does is it allows for education. And so I focus very heavily with all my staff on what do you want to learn? And then we also talk about what does everybody in our team know and where are our gaps? So then we kind of pick from our gaps, and everybody starts to figure out, okay, I'm going to work on learning this, or this. A lot of that, of course, focuses on applications, right? We have Epic, and so we leverage that. They have a learning environment for us that's a part of the suite of tools that we get. So, we focus on folks learning and doing that. But also, like other things, if there's a local regional HIM conference, I'm going to look and see what I can do to budget for people to go to that. But if I can't budget for it, I'll at least give them time to go to that, because when they go, I ask them to make sure you bring something back for your peers. So you bring something back and say, this is what I learned. This is something I think that you guys would be able to kind of grow from, because that helps with the data governance components so that everybody gets familiarity and some exposure. Or like for myself, when I go to those different things, I try to bring back information to be able to help with that. So I think from that perspective, there's a lot of the HI professionals and the IT folks on my teams kind of marry up in that sense to be able to help make sure we're capturing things in a way that's going to be useful long term versus just being a free form note. That's, we got to rely on some natural language processing technology or other AI machine learning type technology to get the information out for us. So that definitely adds value in that way. But I think for me, the big thing is how do we continue to help people pursue what they're interested in and then also pursue what helps the team.
Yeah, very good. I wonder, how I referenced those network diagrams earlier, and I was thinking about how, I've seen so many of those. You guys have probably seen way more than I have, where you've got the servers and you've got all the different, I don't know, databases that they're connected to and all those different things. And so what I was trying to do in a previous role was, hey, I want to know what all's on each of these servers. And if there's redundancy, where do those roll to? And I want to be able to say which applications are on each of those. And not only that, I want to say what content is on each of those, within each of those applications. And I think that they thought I was crazy. I think they thought I was overkill, but isn't that a good plan for redundant, or for not only redundancy, but for tracking down where things have been hijacked, or where things get lost, or where you can back up and find a previous copy you know what I mean? Is that not a good plan? You guys are in IT, you tell me, is that too much?
No, it should be. It's a very good plan. And it made me think of back in the privacy officer days. We knew where all the paper was and we tracked all of those pieces. So
the paper was.
In my mind, I'm sitting there going, all right, as part of my risk assessment of the privacy officer, I probably should go through all of these applications and application databases, the infrastructure of where they live, whether it's on-prem or off-prem, because that's a whole other complication today, and how that information is transported, and then hit those vendors. Imagine you're in an off-prem situation with information stored in a cloud server. Well, where is that cloud server backed up to? An IT department, again, they're going to go, why are you asking this? Like, I don't know. But we as health information professionals are curious. We should know where this is going. And, Daniel, you mentioned the 21st Century Cures Act. That brings in all kinds of complexities of things that are occurring. One of the things we mentioned, or we heard you talk about in our previous time together, was some of the complexities of what you deal with on a daily basis outside of just general acute care, but jail care and the effects of the 21st Century Cures Act. Could you expand on that a little bit?
Yeah, well, just real quick touch on the last topic too. One of the things that I learned about was it's called the Privacy Impact Assessment. So I'd encourage you to go check that out if you're not familiar, because I think that hits the note on what you're getting at, Shannon, with what information are we capturing? How long are we storing it? Where are we storing it? Is it in an encrypted state? All those different things. And that's something that's very commonly used, from a federal government perspective. They require it for most things. And really, when do you do a privacy impact assessment? Whenever you have a process that changes or you're bringing in something new. Just all the time.
Almost daily.
Never ends.
It's untenable. I'm like, how do you guys do that for all those situations? But I think if you start with that as a baseline, like, hey, does our organization even know that information, to your point? And then I think a lot of times if you can approach it if you can leverage and look at other systems and processes, like federal government usually is a good place to start to go, well, what do they do? And how does that translate maybe to our world? And then sometimes I find that that's helpful in my interpretation, right? Or translation between IT speak and HIM speak and everybody else.
That's good.
So that's what I look for in that. And I think the privacy impact assessment was one that I find is probably not done as much as it should be outside of the government sector.
Yeah.
But to your point earlier about, how the complexity of healthcare, right? So like jail health is very complex. Like we were looking at the 21st Century Cures Act. Well, we got to release all the patient's information to them immediately upon availability, barring a few weird situations, right? Maybe some things like HIV, you got to tell them in person or over the phone first. So you can't release it to MyChart or your patient portal. But with jail health, we had to block a lot more than that, because what we found in the past, before the patient portal was really even a thing, when a rival gang member found out where somebody's going to be transferred for outpatient therapy from the jail to there and then back again.
Mm-hmm.
They showed up at the outpatient clinic to say hi.
So scary.
Right? And that's a huge risk, not only for the patient, but also for the entire staff that work there. And we talk a lot about violence with healthcare workers. It's a huge epidemic in and of itself. So how do you protect those folks? And you got to be really thoughtful about it. So, we sat down with legal affairs, say, well, what is the minimum things that we have to share as a part of the 21st Century Cures Act? Most inmates don't have internet, right? They don't have Wi-Fi or anything available to them in their cells. And their families, though, also might have access to the records, because a lot of patient portals have proxy access. You can set it up. And then, hey, maybe it's not a rival gang, but it's somebody that wants to help you escape, or somebody that, doesn't like you or whatever.
Yeah. Somebody wants to bring you drugs, right? So
right.
Maybe it's your dealer. I mean, seriously,
right.
could
or
be.
bring you some cigarettes so you can sell them when you get back inside. It's but at the end of the day, those are things we had to be thoughtful about. So then how do we build a system that releases all the information that's necessary, but no future appointments? So no future anything, but all the past stuff is readily available.
Wow.
And so it's just being really thoughtful in that approach. But I think if we didn't have the HI professionals, not just in IT, but also on the operations side, involved with legal affairs, involved with our, chief privacy officer, our chief information officer, and everybody else in that process, we wouldn't have really been as thoughtful about it. We would have probably created us some, at least some minor risks, if not given us some opportunities for, what is it? Information blocking, right? And so I think, that all takes everybody working together. But at the end of the day, it's just, I think you got to share that information when you have the opportunity. When that opportunity presents itself, volunteer, see how you can get involved. It's going to feel like you don't have enough time. You probably don't. But try to figure out a way that you can provide some support. It's an interesting space now. I think growing up, the idea of work-life balance wasn't even in the vocabulary. You're like, what? No, I'm just going to work 80 hours a week, go to school full time, and everything's going to be fine. And was it? No, it wasn't, but it was.
But we made it, right? We're still here. We're still here.
Probably have some extra diagnoses, because of them.
Right.
But I think in today's world, you do have to strike a balance. You got to figure out, how can I give information but still protect myself so I can, be healthy on my own.
Yeah, absolutely.
Yeah, it's interesting, the complications of creating the medical record in an electronic format in a jail world, which I'd never really considered, is just fascinating. And it's unintended consequences from legislation. And that's something you and I work together on at the Advocacy and Policy Council. So we'll close on this question of, and you've kind of already touched on it, which I like, but I'd like to understand how you see the importance of advocacy in the HIM professional or HI professional realm for all of us.
Yeah, I think first and foremost, people think about advocacy or lobbying or going to DC, and it makes them a little bit nervous, or they're like, we're all advocates. The moment you're at that Christmas dinner, and they say, what do you do for a living?
That's right.
Right. You got to have something that's simple that people can understand. Because if you give them the complex stuff, which we can, they just turn off.
Yeah, you lose them.
And it's the same thing when we work with people in IT or in clinical settings. If they want to have you turn off, they give you the $1 million words that they've learned. And you're just like, okay, I don't think the patient understood a lick of that, but thanks. Yeah. So I think that ultimately we all are advocates every day, whether it be with our family, just saying what it is we do for a living, or telling your friends, your family, even young people that, hey, do you have a living will on file? Do you have a medical power of attorney? Do you have all that documentation that we know is crucial to getting care when you're not able to speak for yourself? Those are things that I think are really important. And we do that on a regular basis. So for me, we advocate all the time. I think where, to your point earlier, in some of the work that you and I have had the pleasure of working together on, it's going and talking to the legislature at the state level. We've seen that be paramount in this time and age, where the states are driving a lot of the restrictions or ability to seek and get access to care, or even just access to some of those dollars. We saw during the Affordable Care Act, some states just refused to take any of that extra money.
Yeah.
So I think for me, it's paramount that us as HI professionals who have the stories to share how this impacts people, how it impacts health, how it impacts safety for patients and employees and healthcare providers. We have the stories. We understand how it connects from A to Z. And if somebody in Congress is more worried about the finances, we can attach it to that. If they're more worried about how that impacts human beings, we can attach it to that. And so I think as an HI professional, we bring that wealth of knowledge, and it's just a matter of talking to people. And you know, have you seen them on TV? Yeah, but are they a celebrity? Not really.
Yeah.
You know, they take a shower just the same way you and I do, put their
Yeah.
pants on one leg at a time, right? Whatever the phrase that makes sense to you is. But I think for me, it's just a matter of speaking up and speaking out, you know, and it doesn't matter if that's in a situation where I'm advocating for health information, or I'm in that meeting with Shannon and I saw somebody talk to her in a way that I thought was rather unprofessional. And I'll speak up for that to make sure that together we can create a community and an environment that's healthy for us all.
That's awesome. Well, Daniel, thank you so much for spending some time with us today. And also, just for anybody who may be watching this on YouTube, we're recording this at 'tis the season kind of time of year. So Daniel's sweater is awesome. And you'll be watching it maybe March or April timeframe, February, March, I'm not sure. But his sweater is incredible. Oh, I love it. But Daniel, we appreciate your time. Thank you for joining us. It's been incredible. I appreciate you and Seth talking about IT and HIM together. And you both are very much advocates for the profession. And I'm just really honored to know you. So thanks so much.
Thank you for the opportunity. And it's a pleasure to have worked with you through the House of Delegates for the last many years that we've been over there too.
Been good.
Yeah, and we also want to thank today's sponsor, which is FairCode. Are you looking to maximize your hospital's revenue and streamline patient documentation? Introducing FairCode, your trusted partner in DRG reimbursement optimization. FairCode's 100% board-certified physicians collaborate seamlessly with your coding, CDI, and medical teams to conduct lightning-fast chart reviews, pre-bill and post-discharge to ensure accurate reimbursement. Only 10 to 15% of the chart's FairCode reviews requires changes, yet their recommendations result in a significant boost to a health system's cash flow. Are you worried about risk? Try FairCode's 13-week trial. If they can't pay for their services, they'll keep reviewing charts until they do. And by the way, historically, FairCode's 13-week trial leads to an ongoing partnership with a remarkable 3-to-1 hard dollar ROI. Don't miss out on the opportunity to enhance your reimbursements. For more information about FairCode and how you can experience the maximum in healthcare revenue optimization, contact Steve Hansen at 615-600-2166. Shannon, until next time, my friend.
Until next time.